My name is Christina Iptoma, and I am mom to OsteoAngel Dylan and Director of Scientific Programs at MIB Agents. Welcome to the first episode of Season 6 of OsteoBites. We started this podcast in 2020 during COVID, and today marks our 143rd episode of OsteoBites. And who better to help us kick it off than Dr. Damon Reed to discuss the Children's Oncology Group Blueprint for Bone Tumor Research. Thank you so much, Dr. Reed, for joining us on OsteoBites today. We are thrilled to have you. Please feel free, everyone, to submit questions during the presentation through the Q&A in Zoom, and we will share those with Dr. Reed after his presentation. A bit more about our guest today. Dr. Damon Reed wears many hats. He is the inaugural head of the Division of Pediatric Solid Tumors and Chief of the Pediatric Sarcoma Service at Memorial Sloan Kettering Cancer Center. He specializes in the care of children, adolescents, and young adults with sarcomas and other solid tumors. And he has a particular expertise and interest in studying the changes that happen in tumors to make them resistant to therapies. In his research, he's exploring how to best combine and sequence therapies to maximize patient outcomes. This includes targeted therapies that take aim at the molecular changes fueling cancer growth, as well as conventional chemotherapy, immunotherapy, and the timely incorporation of surgery and radiation therapy. He's also involved in early phase clinical trials to assess new therapies. In addition to caring for patients and conducting research, he also holds leadership roles in multiple collaborative groups. Dr. Reed founded the Sunshine Project, the Pediatric Cancer Foundation's Pediatric Phase 1 Clinical Trial Consortium, and he also serves as the Vice Chair of the Bone Tumor Committee for the Children's Oncology Group, and he is just rolling off having served as the 2024 President of the Connective Tissue Oncology Society and International Society of Sarcoma Specialists. And we are honored to have him and benefit from his expertise on the MIB Agents Scientific Advisory Board. So for this presentation, he's going to be speaking from his perspective in his role as the Vice Chair of the COG Bone Tumor Committee. Thank you so much for joining us today, Dr. Reed. We're really looking forward to your talk. Just a couple quick announcements before we get started. Hopefully Factor 25 is on everyone's calendar already, June 26th to 28th at the Grand America Hotel in Salt Lake City. Abstracts are due tomorrow, Friday, January 10th. And for those of you who like to wait till the last minute, I'll also note that the deadline's 11:59 p.m. Eastern Time. So if you haven't submitted, you still have time. Travel award applications will open mid-month and registration will open in February. So I'll put some more info about that in the chat. Also, MIB Agents is assembling a team to represent at Childhood Cancer Action Days on Capitol Hill in DC, February 27th to 28th. If you've ever wanted to share your story with a congressman or woman, it's a really impactful way to share that experience. And now is a really good time to do it. I will share again more info and an email contact in the chat for more information. And lastly, we are accepting applications for our 2025 Junior Advisory Board. Our Junior Advisory Board is really the heart of MIB Agents. They help make sure that we stay focused on patient-centric initiatives, and they serve as powerful advocates sharing patient perspectives with the scientific community, regulatory, and legislative groups. So if you know of any osteo warriors or siblings ages 15 to 22 who might be interested in this opportunity, please share it with them. Applications are due January 20th, and I will put a link in the application in the chat. So those are all the announcements for me today. And with that, I'm going to hand it over to Dr. Reed to start sharing his slides, and we'll get on with the presentation for today.
Thank you so much, Christina, for the wonderful welcome and fantastic introduction. That's perfect. And I am exactly going to present as the Vice Chair of the Children's Oncology Group today, kind of representing that institution in those thoughts, which I feel very strongly about. So it's going to be great. If there are some questions along the way, I trust Christina's judgment to kind of facilitate and figure out if we, but keep them coming. And if it works better, not all lumped at the end, that would be fine with me too. So great. So again, I am Damon Reed, and I'm here in New York at Memorial Sloan Kettering MSK Kids, presenting on behalf of the Children's Oncology Group's the committee. And the scope of this presentation is the blueprints paper, and so I'll talk a little bit about the context of that paper from 2023. And like everything, it was not Christina that was behind or at fault for why a 2023 paper is being presented in 2025. It was definitely mine. And so there's scheduled a couple times, and I appreciate being able to present it today. Slides are projecting well. Okay, good. So I'll hold up the COI disclosures of the various members. And so mine are that have been on the Data Safety Monitoring Committee for 2 trials, one sponsored by ASI, the OLLI trial, and SpringWorks, a desmoid trial with nirogacestat. Steve Du Bois's COI, ODM PDTAs, and the chair, Dr. Janeway's, Katie Janeway's COIs are just shown there for the informational purposes. So I thought before we get into how the Bone Tumor Committee thinks about osteosarcoma from a COG perspective, I thought I'd provide a little bit of context to the Children's Oncology Group, because I think COG is thrown around a lot, but I just think it's helpful to introduce to those of the audience members that are a lot less familiar. So the Children's Oncology Group is the world's largest organization devoted exclusively to childhood and adolescent cancer research. 12,000 experts united across 220 hospitals in our country, Canada, Australia, New Zealand, Saudi Arabia in the fight against childhood cancer. And that means that reach allows for 80% of the 15,000 children and adolescents with cancer to each year to be cared for at COG institutions. It has a clear mission to improve the cure rates and outcomes for children with cancer, and it's led very ably by Dr. Doug Hawkins and Leah Gore as the vice chair overall. COG works on educational resources, new diagnosis guides, and has an app and other things, and survivorship and all kinds of good things that the Children's Oncology Group does. What it's really known for is trials, and the Children's Oncology Group is excellent at doing the larger trials that need accrual across lots of institutions, and has over 100 clinical trials open at any given time, with 12,000 patients registered on children's oncology trials each year. That does not mean 12,000 people are on trials where they're getting new medicines necessarily, because there's a registry and biology studies. But again, it has a great reach for things and able to do the studies that are often practice changing and establish the standard of care. A lot of times these trials are frontline treatment for many types of childhood cancers. They facilitate understandings of the underlying biology of these diseases with uniformly treated patients and good collection of biomarkers and other materials, and evaluates new and emerging treatments mainly through the PEP-CTN, the developmental aspect of the Children's Oncology Group. Supportive care and survivorship are also within the scope of the Children's Oncology Group, and I talked about who they are. The Children's Oncology Group needs money to run, and that's where we're going to go next. And so it is ultimately funded by federal grants. And so I want to talk a little bit about the ecosystem, because I think a lot of people find the Children's Oncology Group unnecessarily complicated, but I think it is helpful to kind of say where it lives, since it is funded by federal money. It lives in a certain system, and so the org chart that I would follow up to is, I think people are familiar with NIH, or the National Institutes of Health. And the National Institutes of Health is caring about health of humans of all kinds. More specifically, underneath one of that huge umbrella of the National Institutes of Health, there's the National Cancer Institute, the NCI. And then underneath that is the Cancer Therapeutics Evaluation Program. So for cancer now, talking about the evaluation of new medicines, that's the acronym CTEP. And for pediatrics, we have had Dr. Seibel and Smith, who have been assigned and have been taking care of the pediatric studies for a long time. And then the trials underneath those are is the NCTN, the structures, the National Clinical Trials Network. And the Children's Oncology is the pediatric example of the NCTN studies. And so about, I don't know, sometime around 10 years ago, these separate, the Southwest Oncology Group and some others, were really reorganized into this NCTN with some more centralized functions. And the Children's Oncology Group was incorporated in this as well to kind of make sure that there was a little bit more towards the federal aspect of things. The budget entirely for the NCTN, I think when I looked on a website, one of the cancer.gov websites, it was about $171 million for all of these clinical trials going on in all cancers. And again, COG is part of that. So sometimes people get into, like, when the Children's Oncology Group study happens, I think people wonder, just write a trial and get it started. And I think that the reason I wanted to show some of that hierarchy and other things is that there are evaluations that happen at the COG level, and there are things that happen at the CTEP level towards the activation of a trial. And so, again, I'm on the Bone Tumor Committee, and a concept might be written and developed. It'll be reviewed at the Children's Oncology Group, and this is just an example trial. It might come back to us with some additional details. We might address those and get approved by COG, and then it could go somewhere else to the next level of review, which is the Cancer Therapeutics Evaluation Program. And sometimes trials don't make it through. And so there are a couple levels of review, but even with this, there are many trials that are open. I try to show everybody once on this, and people have played many roles in this system, and there's kind of a natural progression in some ways. The past chair of the Bone Tumor Committee was Dr. Richard Gorlick, who is currently involved in the CTEP reviews now. And so there are people that know osteosarcoma at all levels, is what I wanted to communicate with this slide. And so that's one of the ways that the structure is. And so every 5 years or so, the NIH asks that the Children's Oncology Group grant and funding is not forever. It's not evergreen. And so there are times when they want to know, as any taxpayer would, what's going on with the resources that the government are providing for the Children's Oncology Group. And there's a grant cycle where the Children's Oncology Group has to be condensed to 12 to 18 pages. And that's impossible. There's just too much stuff going on, and I hope I've communicated that with the first couple slides. And so instead of that, the Pediatric Blood and Cancer Journal has always been gracious enough to allow these articles, which we call the blueprints articles, to allow each committee, in our case, the Bone Tumor Committee, to write about a 6 or 7 page paper. And this serves as the background for the tighter grant that the Children's Oncology needs to write. So the Children's Oncology Group then could write their 12 to 18 page grant and refer to this for the greater details, so that all the work that the Children's Oncology Group can be captured for that the grant review. Towards hopefully the Children's Oncology Group continuing to be funded, which has been the case for this entire century. And so I got to write this with this fantastic group. Here are all the authors. The ones that are not pictured later on in the slide deck are pictured here. So Mark Cralo, our past statistician, Dr. Odion Benitier, who's an orthopedic oncologist at Moffitt Cancer Center and in charge of the vice chair from local control. Dr. Steve Du Bois, who's the vice chair for publications. And of course, our leader, fantastic leader, Dr. Katie Janeway, is also pictured. So again, this was published last year, a year and a half ago now, and accepted. And so today's agenda, thus, in that context, is going to be to talk about the Bone Tumor Committee. I will briefly mention Ewing sarcoma for this audience, and osteosarcoma. And then I'll just follow the paper, which was the state of the disease clinical, the state of the disease biological, and major recent findings, and then go to the strategic approach. So this was kind of the past, kind of what happened with the last grant cycle, and then the future. So what we aspire to do with the next grant cycle in terms of the strategic approach and the key trials to be pursued. So again, I mentioned that I would talk about Ewing very briefly, and here it is, the Ewing curve. And so this is what's shown in the paper, but I think there's a lot of times that you can get a little cynical or a little nihilistic in bone tumors and say there hasn't been any changes in this many decades or this many decades. And so this is VDC chemotherapy for Ewing sarcoma, and then a cooperative group study with adding ifosfamide etoposide and then changing the schedule has shown improved survival. So I think that this is, of course you want to lead on a grant with something that's positive that came out of things. And so again, chemotherapy intensification by adding agents and making it more dense has definitely improved the outcome for localized Ewing sarcoma. And so that's the first figure that leads things off. And I don't think I'm going to be mentioning Ewing sarcoma again for the rest of the time. So as we continue to walk through the paper, we start with challenges in osteosarcoma. And I think that that's important. I think that it's unfair to just say, this cancer had this happen. Now just do that, copy paste, and do it in osteosarcoma. I think there are a couple things that we wanted to get across that complicate trial design, not excuses, but just things that are. And so we talk about them in terms of challenges and then kind of how we've worked to overcome them. And so we, as the committee, are definitely focused on identifying drugs, ideally new drugs, with signals of activity in the relapse setting that can be combined with chemotherapy in trials in the newly diagnosed setting to improve overall survival. So that's, if you just boil it down, it's in there in the blueprints. The disease that fails MAP chemotherapy and surgery comes back. That disease, awful. We don't want it to happen. When it happens, we use that disease, those patients in need, many ideas as we can from as many sources as possible to try to think of what the best therapy could be. And if those therapies show some signal of activity, then we wouldn't want to put that in our back pockets and never use it again. We would bring it up front to try to improve the curing. That's it boiled down. With that in mind, it's hard to shrink osteosarcoma. And so that's the first challenge that's mentioned is osteosarcoma-specific endpoints are required because osteosarcoma is fundamentally malignant cells and abnormal bone, malignant osteoid. And so I've been taught that if you kill a turtle, it still has a shell. And so it's not easy to shrink osteosarcoma. It can happen. It can happen if there's not a lot of bone that's laid down. There's not a lot of matrix. But certainly in newly diagnosed patients, it's not common that you expect the tumor to shrink. And so those are things that we use in clinical trials. And when you don't have a tumor that's very dynamic, it's harder to say easily that the therapy is doing something.
Dr. Reed, can I ask you a question just back on your last slide on that kind of main overarching thing? And stop me, because I think you might be actually getting to this, I think, in some future slides. But bringing drugs that have signal activity in relapse setting to upfront therapy, newly diagnosed. But it sounds like a part of that, or important part of that, might be risk stratification, because I know another important goal is to minimize toxicity so that you're not also like over treating patients that don't necessarily need that. And so will you be addressing risk stratification as part of that?
Yes. So good. So yes, I will be addressing that kind of aspect. Good. So that's good. And so as a representative of the Children's Oncology Group Bone Committee, our goal is not to just keep adding therapies indiscriminately. I think that's a very important point. So thank you for that comment right there. I think I'm going to go for a little bit in the way I planned, if that's okay. And what it will get to is how we're trying to do those kind of things. But yes, you're right that it is true that not every single patient has the same chance of having what I just described, of doing MAP and surgery and all those things and having disease relapse. So being able to identify those patients better and then potentially using drugs that do something in relapse and bringing those up front would be even a better strategy that we're trying to work on. Yes.
Okay. It sounds like you're going to get to that. So apologies for derailing.
It is a little bit in here, so but it's very good. And so we were talking about it good. And if I don't get to it by like 10 minutes from now, then re-ask it, or I'll just bring it up again. So good. So then challenges in osteosarcoma, not very dynamic, don't shrink very often. And so what I would do, and the paper also does as well, and so I have up there like lemonade. So when life gives you lemons, like make lemonade. And so we did conduct, or the precursors to the Children's Oncology Group, those are these CCG and these other P protocols. Once you get to this nomenclature of 4 letters and numbers, that's the Children's Oncology Group study. So a series of agents were studied in phase 2 studies in osteosarcoma, trying to see if something could happen in terms of shrinking or preventing osteosarcomas that are measurable from growing. And Dr. Lagme, with Dr. Janeway's leadership, and this large team looked at all those trials, these 8 trials, and said, these were all negative trials, no clear signal of activity, and said, here's how patients do when there's measurable disease in osteosarcoma. And so this 1.0 could be 100 patients walk in the door, and you put them on any of these eight trials, and by 10 months, only a small percentage of patients, single digits, have have their disease stable. And so you see a precipitous drop off, and osteosarcoma is progressing really at its own will on these agents. And so that's not good news. That's the lemons. The lemonade is saying, well, all these patients went on these studies trying to get something good, but let's use this as a benchmark. And this is rather awful. This is not a good outcome. And so we don't need a million patients to try to show that we can do something better than this. But I want you to remember this curve. So the lemonade made out of from the Children's Oncology Group is that past trials have been negative and the outcome is bad. So you don't need many patients to screen through and figure out things. So doesn't mean we have to put 30 patients on to figure out something is not working. It doesn't mean that we would need to put 30 patients on to figure out something is working. We should be able to detect the signal early. Another challenge with osteosarcoma is we know surgery for relapse, and most of the times relapse are in the lungs. We know surgery is important. Surgery is the chance for cure. And so a lot of times patients come in with a relapse in the lung and they want the tumors out, and we want the tumors out, and the surgeon can take the tumors out. And so, when the track record is that leaving it in and treating is this bad, you don't really want to wait a while to get to surgery. And so a lot of patients have surgery, take surgery up front, so there's no disease to monitor. And so that's another challenge. Challenge is that it's hard to say your drug is doing something when there's no disease to shrink, and a disease that doesn't shrink very much. So another challenge that's raised in the Blueprints article is that a quarter of the population undergoes standard of care surgery. And so, but again, there was at least one trial conducted about 20 years ago where we have a track record of how the patients did. And so we again have a benchmark of how patients go. And so we have conducted, the Children's Oncology Group has conducted, and some of these predate my involvement in really any decision-making or leadership or any involvement at all. These 2013, 15, 13, 14 clinical trials, they have been modeled after that curve that I showed in the first curve and the second curve. So we've used these benchmarks so that we can study one agent. We don't, in these cases, have not put patients on placebo or no drug. So we've been able to say there's a historical control. It's not good. Let's study this new drug that we're excited about. Let's see if it can do that. So these benchmarks have been very productive for people to do trials in the Children's Oncology Group and these top versions, and also outside the Children's Oncology Group. And I just show these two examples here that we included in the paper. And so, so that's one thing, is that the trials have been negative, yes, but the trials have been, we've been able to do trials where everybody's getting the most active agent that we can think of, and where we've learned something from it. Unfortunately, learning that they have not had a ton of clinical activity. So this is where I get to your question, Christina, which is that these trials, when trials are happening, we're able more to collect quite a bit more information and learn more from individual patients, but also to bank tissue and to kind of stimulate the idea of we have the best osteosarcoma scientists in the world that are interacting with the Children's Oncology Group. That there's a monthly meeting. It happened yesterday. And they want to bring their ideas. They want tissue so they can learn about osteosarcoma. And when trials are going on, that all goes much smoother. And so I wrote in the bank. And so there is a tissue bank, a tumor bank of osteosarcoma that Richard Gorlick started many years ago, and that now Jess Davis, pathology in Indiana, and Kelly Bailey, and many others are working a lot on to make sure that we get good clinical information and good samples from patients. And so while these trials were negative, priority biology questions and support of basic science has improved dramatically over the times of the conduct of these studies, with 939 distinct patients having a tumor banked through a biology protocol, AOST06B1, no therapy, just biology collections, and stored at the Biopathology Center. And so, so the phase 2 trial conclusions are that we have benchmarks for measurable disease and for resected disease. And we have found that there's rapid patient accrual. This includes not only pediatric patients, but young adult patients. And that our conclusion is this is an unmet need. Osteosarcoma is a clear unmet need. Now, I don't think people on this call needed to know that. I don't think people on the Bone Committee needed to know that. We all kind of knew that, but we've been able to prove pretty unequivocally to the outside world that, osteosarcoma is not so rare that you can never do a trial. Like, we did a lot of trials. And so I think that the unmet need has really led to quite a few trials in the last decade. And so I would credit that 2016 Lagway, Janeway et al. Paper. The osteosarcoma-specific endpoints are widely adopted in and out of children oncology group studies, and the paper's been cited 120 times, meaning that a lot of people are using that kind of information. That's kind of the metric here in our academic medicine for the importance of a paper, with that being a very high number of citations. And meanwhile, while all these things were going on with different chemotherapies that were studied, TKIs happened. And so we'll get to tyrosine kinase inhibitors in a second, but and how they have cleared the bar. So in the bank, also the biospecimens have been distributed to 26 different projects that show Brian Crompton, and we'll go into a little bit of a critical partner that the Bone Tumor Committee has been lucky to have that precedes me again, but fortunate to see all the work that they do. Results of these studies have provided proof of principle for biological subtypes, and that gets to what you're talking about, Christina, in terms of because we did trials, we got samples. Because we have samples and someone made a bank a long time ago, people have been able to ask questions. And because of Katie's leadership and everyone's inquisitive nature, it can't be that every osteosarcoma is the same. And so we are trying to figure out how to figure out subtypes of what patients could do well with surgery and some chemo and all those sorts of things. And unfortunately, osteosarcoma has been rather complex from a genomic thing, and I'll touch upon that too. But these samples, and I highlight a couple projects like Sarah Whittle's Texas Children's is working on MYC amplification I think people have heard of that as a biomarker of poor outcome. And then again, Brian Crompton's fantastic work that he leads with others about the presence or absence of ctDNA diagnosis and maybe how it changes over time, being an earlier predictor of outcome, even adding to what we know about necrosis and perhaps weighing in. And so a lot of samples came in, and that was great. But at a certain time, my understanding from the history is that it was not easy to organize all these samples, and it was not a perfect system, and so things got a little bit out of control. And so Quad W, what we really want, and this team that's pictured here, also led by Brian, and developed a way of kind of annotating and improving on the bank. And again, specimens at Children's Oncology Group were contacting me if you want to try to use any of these samples. So then people had a better idea of what they were, and then people would apply and they would say, oh, there's too many levels of reviews and it takes too much time. And everyone I'm showing here now for the first time, Patrick Grohart, Vice Chair of Biology, Ryan Roberts, who does many efforts in the biology space for osteosarcoma, familiar face to this audience for sure, realize that yes, we have samples, yes, they're annotated, but the process of review is still too much. And so they've streamlined the process. And so I think things are going in the right direction, and all of this is meant to be captured in the paper. This is a little bit more detailed than is in the paper, but it just shows each green bar that's horizontal there is showing a project, and quite a bit of detail in there in terms of names and stuff like that. But what I'm really just trying to show here is that these triangles are milestones of the thing was submitted, it was reviewed, comments came back, it got to the IRB, it did all the various things, the steps of research. And you can see that there are times when there's gaps for sure, but the fact that there's this tracking now and things like that have really sped up the back and forth to move these things back to completion a lot quicker. And so one of the biggest problems that has been solved moving forward, and this has kind of happened over the past few years, and I think, again, another shout out to Dr. Brian Crompton is warranted here, is that a new idea happens, and we want to put it on a trial. And the new idea happens because a site figures something out, and they say, oh, we have 13 patients, and we have this kind of little bit haphazard way that we collected all the samples that we could, and we put it together, and it looks like there's something here. And we say, we want to run that on a Children's Oncology Group study. And they say, one of the levels of review says, you need to know for sure that's happening. And then the researcher says, well, no, I need a COG. I need the Children's Oncology Group. I need your samples in order to prove that it's working. And so the Children's Oncology Group says, no problem, we'll fund it, no problem, as long as you can show it's working. And the person says, well, I need your samples to show it's working. And this catch-22 happens. And so QuadW has also done a very good job of funding the pilot programs to say, we'll pay for the sampling. Let's get out of that loop of nonsense. And again, Brian's done a really good job of getting critical samples, and then the success of those samples, showing how important ctDNA is with larger and larger cohorts, is making that something that we can now test prospectively, which is very important. And so there's been some breakthroughs on the preclinical side. I mentioned a whole bunch of things in the bank, and again, Jess Davis, a pathologist, has a team of other pathologists as well, looking at cases and looking to see, is that tumor that we think that's in that one spot in the freezer, is that, or in wax, is that really osteosarcoma? Is it really a specimen that got chemotherapy? Is there really 60% necrosis? And they're looking at hundreds and hundreds and hundreds of cases, and making sure that it's been a very important quality of improvement project, making sure that we can, when someone thinks there's 400 samples in the bank, that there really are 400 samples in the bank. And so all those kind of important things are happening. And so that's banking. And then another thing that has happened with banking, and another thing that's been revolutionary in just the last 10 years, and now childhood cancer care, has been genomics. And so, I'm old enough that we used to sequence one gene at a time, 750 base pairs to be more specific in the lab that I was working in. So you got 750 C's, T's, A's, and G's, and then you kind of strung it together and you made some sense of it and used some software to kind of make some sense and find a mutation. But now people can look at the 3 billion letters instead of 750 letters, and people can look at all the genes at the same time. And so revolutionary, right? And so another one of the challenges of osteosarcoma is this is a normal genome, 2 chromosome 1s, 2, 3, all the way down. In this case, XY, this is a boy, just a normal genome. That's what it looks like. And this is a Circos plot of a normal genome. This is all 3 billion base pairs, no mutations, just a normal kind of looking thing. Over 10 years ago, some of the samples in the bank were used in an initiative called Target. So we were looking for targets, but the initiative is called Target. And what we know about osteosarcoma is that p53 loss is, I'm going to say, nearly universal. You can get people to say different percentages if you want, as are alterations in cell cycle genes. And so in Target, instead of having these 46 chromosomes, the chromosomes are a bit more chaotic in osteosarcoma. Instead of having normal genes everywhere, you see a whole bunch of lines in the middle of that circle, a whole bunch of genes that are broken off and stuck onto other genes in osteosarcoma. And you get a sense, as I first heard at the first factor meeting in Miami, that Dr. Meltzer said that osteosarcomas are like snowflakes. Each one is different. And that is true if you look at the DNA level. They're different. And so, in fact, if you look at all cancers and you say breaking DNA and having it stick back together, what has it the most? You normally in childhood cancers, you find quieter kind of things, but you look all the way to the right and there's osteosarcoma, the highest of all cancers in this Nature Communications paper in terms of breaking of DNA and sticking it back together. With Ewing sarcoma and other things, the break and put back together is almost always the same 2 genes. And osteosarcoma, this is just happening all over the genome. And so that's what you see. So again, in the DNA, from a DNA level in osteosarcoma, subtypes have been complicated because there's so many changes. This is an old St. Jude paper in 2014 with lots of translocations, breaks and hooking up different DNA across chromosomes, lots of mutations of genes. And here's another way of looking at it, grouping it by p53 mutations here, RB mutations, and other things. And so subgrouping again by target, which was the hope and the promise, has been complicated. It's not super clean, with maybe some thought that there might be some more favorable outcomes here or otherwise. But at the moment, DNA alone won't be used to subtype or change therapy, is where we're at. So with all that DNA changes, one of the debates in the field that is not known, with good data shown, saying that what I'm about to say is not true. With that DNA instability, the question is that ongoing or not? We certainly think cells that have been for millions of years, that have been, or at least hundreds of thousands of years, a million years for Homo sapiens, has been designed to have 46 chromosomes. For it to now have 60 chromosomes and a whole bunch of different pieces, it does seem like that's a stress and something that we can exploit in therapy. And so is the DNA instability ongoing? Can we attack things like BRCA, NIS, or loss of DNA repair genes? Is there something about having that much DNA and trying to divide it that makes things relatively common? I mean, almost everyone believes that that's one of the ways chemotherapy works, is by taking that stress on the DNA and amplifying it. But that's one thing that we think is a possibility. But unfortunately, bottom line, the omics story has not made clear subtypes in of itself. DNA is the basis of the phenotype of cancer. DNA turns to RNA, RNA is turned to protein, and protein turns to a phenotype. And so the work and the technologies are now emerging where epigenetic, metabolic, and other acclimations of metastasis and progression are the things that people are looking for. We think, boy, with all these changes, the immune system should pick up on how different an osteosarcoma cell is to another one. And so we wrote that as another potential direction. And then at times, the idea is just find something that osteosarcoma is expressing, something that's on the surface of the cells, and use antibody drug conjugates to bring chemotherapy, very strong chemotherapy, to osteosarcoma. So these are other promising directions that we highlight in the Pathways paper. Now back to those TKIs. And so a quote from the paper: major focus is clinical trials in osteosarcoma, novel therapies. And I blow up that bar of measurable disease here. I stretch it out so that the 10 months is stretched out a lot, so it looks better, but I just modified the figure. And when you tested, the Italians tested sorafenib, it was above the bar. And when Sark and others tested regorafenib, it was above the bar. When studied in China, and lotinib was above the bar, and lenvatinib has been above the bar. And so there have been a lot of studies that have shown that TKIs are more active than the old chemotherapy that was given before, at least in terms of slowing the progression of tumor. And so again, our strategy is stated here, and it leads to the clinical trial that is underway now. So that's what I'll get to. The history is EUROMOS, Europe, America, osteosarcoma is what that stands for. Is the Children's Oncology Group contributed the majority of the 2,000 patients, 2,260 patients who enrolled on this phase 3 trial. This phase 3 trial tested patients with, everyone got MAP chemotherapy up front. And if they had good necrosis, more than 90% of the tumor dead. This trial that was conducted from 2003 to 2011 and resulted and was published in 2015 and 16. Just another important point of the Children's Oncology Group: huge study, international study, 2,000 patients, started in 2003, published 12 years later. So it just does take a long time to do an osteosarcoma trial that's that big. Small trials to look for a signal much quicker. But an immune agent, interferon, was given to patients that had a good response to chemotherapy. Ifosfamide was added to patients that had a poor response to chemotherapy. And this green bar just shows that patients with a poor response to chemotherapy by necrosis do worse. So this is about this is the survival here, about half of the patients, and then about 2/3 of the patients with the favorable necrosis. And so that is the trial, that is the legacy, that's the past. And so building on that is AOST 2032, Dr. Bishop and Glade Bender's trial with now Natalie Dorico as our excellent bone tumor statistician. And so Mark Crowley doing some work at the beginning, and then now her taking over. She's been wonderful to work with. And so this trial is feasibility first to see if we can combine cabozantinib with MAP chemotherapy, and then a randomized phase 2/3 study of cabozantinib in combination. And so the rationale again is there's some activity in relapsed and refractory osteosarcoma. And so first testing, and this is where we are now, the feasibility of adding it, and then to determine if it improves outcome. So the trial looks like this. This is traditional MAP chemotherapy, the 5-week cycles, doxorubicin, cisplatin, 2 weeks off, high-dose methotrexate, and repeating that and going to local control. Patients start with cabozantinib. The details are not perfectly reflected here, so there's different start times depending on when the port is placed and other things, but cabozantinib is given early and before treatment. Separated, there has to be a gap of cabozantinib because it can't be given close to surgery or before the wound is healed, and then cabozantinib is given on the other side. Again, we're working on the feasibility of that right now, and patients have gone on the study. And as everyone knows from public information, it's on hold, and we're amending it, and I'm going to reevaluate patients in the feasibility phase. As always true, there are osteosarcoma patients in need, and so the accrual was pretty brisk in the beginning. I wanted to show real quick, and this is a new slide that I made, that the correlative science has improved pretty considerably, I think, since 2003 when Euromos was designed. So Euromos had quality of life metrics. It did investigate histologic response. It used ALK phos as a biomarker, and it had central pathology for diagnosis and necrosis, since necrosis was a treatment decision that affected which arm you went on the study. AOST, this study, AOST 2032, has quality of life as well. Much better tools for quality of life now than in 2003. That field has done very well. It's really become a really rigorous science. Investigating histologic response is still there, but no longer with central pathology review. But now we add circulating tumor DNA. Prospectively validating that circulating tumor DNA is important and its change matters. MIC and other copy numbers are going to be prospectively validated. And then again, banking, especially frozen metastatic samples, are important in this. I'm also going to touch upon our other phase 3 study, and then I'll talk about it a little bit. The surgical study, it also has quality of life, germline testing, circulating tumor DNA, again, making models of distributable models for metastatic osteosarcoma. And so the correlates have gotten a lot more lab-based and intensive in terms of science, and I think that's a great direction. And so I mentioned AOST 2031. This is a surgical study. For those that don't know, this has roots in the second factor meeting when a survey was taken from advocates and medical professionals about the people's thoughts of this study. And this study is a phase 3 study in evaluating the most important question in pediatric surgical oncology, whether an open thoracotomy or thoracoscopy are they equivalent procedures for metastatic osteosarcoma. And so this is a very important study. Again, very exciting biology going on, but also all patients are getting what doctors consider standard of care. Surgeons include standard of care. There are some strong opinions as to which one of these surgeries is better in some ways, and so the reason to try to run a randomized controlled trial is indeed to try to get the data so patients can make good decisions moving forward. And so this is a study led by John Dosky and Tim Lautz in San Antonio and University of Chicago. And so this study is ongoing as well. Since I'm coming kind of up against time and wanted to have time for discussion, I'm going to keep going. But the one major point here is that I try to use every podium possible to advocate for accruing on this trial. I have a past life of working in institutions that believe very strongly in one or the other. So my career has been randomized by where I've been employed, where I've had patients only get thoracotomies or only get thoracoscopies. And so I do think that there's equipoise for this study, and I do think it's an important study for them. Another study that Tumors Oncology Group is running and that's in the Blueprints article is AOST 2121, the study of the Listeria construct from OS Therapies, an industry-sponsored study, OST 31-164, and this was a study done in the adjuvant setting that has completed accrual, and data is starting to mature for that study is what I could say at this point. So then we talk about ongoing and planned studies and kind of touched upon these ones in osteosarcoma. Other important initiatives in the Children's Oncology Group Bone Committee that we wanted to include in this are we do think that every patient that we have data on, the more we can kind of accrue together, the more we can learn. And so Hibiscus is what we call our big data effort led by Alyssa Rubin. Again, Natalie working hard, funded by St. Baldrick's and Rowley, others, FW. And so this big data is to take those majority of patients on Euromos and get line level data, real detailed kind of data for those patients, eventually building on other layers of biospecimens and other things so we can learn more about all these patients that went first. And so this is in collaboration with the Data for Common Good, led by Sam Volchenbaum at University of Chicago. So progress is being made. We are not the only person thinking of this, and in fact, there are others that are ahead, and we can see the fruits of the labor. And so neuroblastoma and others have put thousands of cases together from all over the world, and they're learning different things about outcomes, and you can make smaller populations larger by collaborating and combining. And so this remains a top priority for the Bone Tumor Committee to deposit Children's Oncology Group data in this database, and also have other countries deposit their data so that we could all kind of learn for the osteosarcoma community. And again, there's lots of patients that have happened, that have gone on these various databases. And so the goal is to try to put all these together over time. there have been plenty of manuscripts published, and I made these slides. I made at least this slide is borrowed from Katie, but a long time ago, and so there's already been progress. These under review are all published now, and so the work is seen through. And so the conclusion, kind of right on time, Christina, is that over the past 10 years, the committee's clinical trials have contributed significantly to the harmonization of standard of care chemotherapy. Again, that's the EURMO study, and that's the basis for AOST 2032. We also want to define the standard of care for surgical approaches, AOST 2031, and so it's an ongoing study. Although we lack an agreed upon risk stratification, we're trying. And so I think that is the right question to ask, Christina. And so those efforts are through banking. That's why those specimens are so important. We'd love to be able to adjust up and down chemotherapy appropriately, never giving anyone too much, like more than they need. We unfortunately remain a bit of a ways away, and I hope I've communicated that the DNA has done us no favors in osteosarcoma towards figuring that stuff out. We still remain hopeful that MEC will be one part of that answer, and ctDNA is very, very promising. So we're working on clinical data harmonization efforts. That's the big data effort. Biospecimens, identifying biological subgroups of bone sarcomas, metastatic sarcomas that we still in every solid tumor in cancer, just any adult solid tumor. Metastatic disease is harder to fix, and so they remain a challenge. And so learning about metastases in that process, obviously, we've had great talks with Brian and Dr. Roberts and other things that have addressed those things. And we're currently studying the addition of tyrosine kinase inhibitors, cabozantinib specifically, to chemotherapy in osteosarcoma. New strategies include, hopefully we'll learn more about the disease, so we'll be able to target it more effectively, and clearly a delineated strategy for the study of new agents. So I think that's all I had, with the thanks to again, I'm just kind of the figurehead here, they're just presenting, but I'm talking on behalf of a lot of people. I hope I've represented them right and correctly. If any of them are on, feel free to get in the chat and improve upon what I've said or correct it. But it's really a pleasure to work for Katie and with this team as well. It's really good. So thank you for the forum.
Thank you, Dr. Reed. That was a big task to kind of cover everything that the COG does in, whatever it was, 30 minutes or less. So thank you for getting through that. Everyone, please feel free to add any questions to the Q&A. And there was one that came through that I thought we could kick off with. It's a great question. So it's about, leveraging the potential of AI and quantum computing in the childhood cancer research space, and particularly in rare disease, rare pediatric cancers, when there isn't much data, right? Because the way that we train AI and machine learning is through lots and lots of high quality, unbiased data. And so that's kind of a huge challenge in terms of setting ourselves up for success to be able to leverage those technologies moving forward. So kind of thoughts on I guess how we can leverage AI, quantum computing moving forward, but how we can also set ourselves up for success to be able to do that.
Yeah, again, I'll do this from a COG perspective. So I think that if the AOST 2032, the MAP plus or minus cabozantinib, that will, at the end of that trial, have hundreds. And I forget exactly the number, like 800 patients, maybe 900 patients that will be uniformly treated. Those patients will have scans at their sites. They will have biopsies, and likely that when the slides are looked at, they'll be digitized. That's happening at a lot of centers. I know certainly Memorial Sloan Kettering digitizes all of theirs. And so these patients will be uniformly treated. They will all have had scans, CT scans, MRIs. Anyone who's looked at an MRI, there's so many points of data there. Again, ctDNA, they'll have necrosis, they'll have pathology and all these things. I definitely believe that the world is getting in a way that we should get to a point where those 800 to 900 patients are data elements, where the size of the tumor is known, how it changes, every pixel on the MRI is annotated in some way, and then the slides are looked at, and as many slides as you can load on to, having some computer optical system picking up on that and saying, I see something about these patients that the humans just can't see. I think these patients do poorly and these other ones don't. Ideally, the machines and AI algorithms can tell us why, but even if they can't, that's still a powerful tool that could help with subtyping. And so I think it does start with uniformly treated patients and data. And what I've realized is that you can walk into a freezer with a whole bunch of samples, but if you don't know where it came from, what the provenance was this pre-treated or not? Is this localized or metastatic? What was the necrosis? What did they get any dose adjustments? Without all that annotation, the samples aren't as good. But I do think that it's more than just chemo and outcome. I think that I'm a big believer in radiomics. I'm a big believer in digital pathology, and so I do think that those are coming. We don't have a massive set like that now, but where the children's oncology can be the most helpful is uniform treatment. Uniform treatment, good clinical annotation.
Yeah. And so along the lines of that, because that's, one thing of using machine learning to kind of analyze that data, but there are also new technologies like, we've seen kind of this explosion in just being able to sequence genome, right? But then now with like single cell level sequencing, spatial transcriptomics, how do you see kind of integrating those new technologies into research?
This is where it's hard in this representing this part of things. I think that the better the technologies get, the more we're able to look at. So I was taught that cancer is a clonal disease, that the cells are fast growing, that they don't have apoptosis, they don't die on their own, and they're immortal, right? And I was taught that cells are all the same. And that's just not true. And so, and then you say each patient is different and each cell is different and everything is totally different. Well, if everything is totally different, grouping them together on a 700, 800 patient trial doesn't make a ton of sense but the scientific method doesn't work very well if every single cell is different and everything that you learn can't be applied to the next cell. So that's where there's a little bit of tension in my just general life as me and all this stuff. But from the Children's Oncology Group's perspective, you try to look for some agents that have a chance with all that heterogeneity, a chance of moving the needle. And I think the fact, and one of the reasons I wanted to show the 8 trials before and the 6 phase 2s since and all that sort of stuff is, it's not like we're just taking some random thing and bringing it up and treating 800, 900 patients. The cabozantinib had to do a lot of things to convince ourselves, CTEP, and all those sorts of things that it has a chance of making a difference for either localized or metastatic, or hopefully both patients. And so I think that that's where it's kind of complicated. So I think that the Children's Oncology Group will run the major studies to see if we can find a big difference in 2 different ways of treating. But we will definitely enable, facilitate, try to use this perch to bring together the right people so that we can find different insights so that our next trial could be even better.
All right, thanks. We just had a question come in. Do you think it's the best approach to move therapies that are active in the recurrent setting to the upfront setting, despite mounting evidence that recurrent osteo may have unique biology relative to primary osteo and the possibility of acquired therapeutic resistance to these new agents prior to recurrent disease?
Are the Bone Tumor Committee, were you still using the hypothesis? And I think that result of AOST 2032, this is science. The hypothesis could be wrong, but our hypothesis now is that something that is active in recurrent disease has a chance to improve the overall survival in upfront disease. The comment from the chat that maybe there would need to be different metrics to identify agents that can improve survival is something I also believe in. I think that alternative hypothesis has increasing support, especially through single cell and other things. Cancers are wildly heterogeneous, and what survives MAP could indeed be totally different than what was present in the beginning. And so I get what's being said, but for today's talk and the mission of COG, we're going to use that relapse signal to try to improve overall survival in phase 3 studies until we have a better idea.
Yeah, you talked about, you had a slide about the correlative studies and how that is super important. And as I think, again, going back to like rare well, it's a snowflake disease, right? And so how there's so much heterogeneity and every tumor is different. And then I also think about, I think my rudimentary, understanding of clinical trial is that, there is kind of this like goal endpoint where you have a certain percentage of patients that have to kind of, meet the goal. And, it seems to me that like, let's say you have a trial with 10 patients and maybe you have one patient that has like this amazing complete response. But because it was 1 out of 10, that trial might not move forward. But it did something amazing for that one patient. And again, if every patient's a snowflake. So I'm just wondering how that, and kind of that tension that you said about like precision medicine, right? Because it's like some patients might respond really well and some might not, but we kind of need to better understand why that patient responded well. And that might still be a really viable treatment for those types of patients. And so wondering how, like, is there a new way to kind of look at how we measure the success of a clinical trial with that context that might not work for the majority of patients, but it might have worked really fabulously for 1 or 2?
There's a lot there. That's a good question. So there's Children's Oncology Group exceptional at phase 3 studies. So in fact, the only way probably to do a phase 3 study in osteosarcoma. And so if you need hundreds of people to answer a question, it's COG. If we go to the second example, 10 patients and 1 does well, we're talking about now like an exceptional responder kind of idea or something like that. I think that the tools now, as opposed to 10 years ago, in terms of trying to figure out why they're an exceptional responder, are so much better. So I think now, most of the time now, it's not like we have no idea why that one person responded. I think it's now, because the drugs are a little bit cleaner in what they do too. I think there's like I think the reason this patient responded is because they were also missing this other thing which set them up to be. So I think we're better at figuring out things like that, so that it's not just that, oh, we tried this drug out in 10 patients, one person did well, let's throw it away. I think we're better at like, hey, by the way, let's publish that this patient had a blah, 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 3 letters usually, mutation, and that's made them more susceptible to this agent. It is harder, of course, for that drug to like move through if it's not approved or something like that. It doesn't really have much of a path ahead, but that's not science, that's business. And that's not something I'm qualified to talk about. But like, but I think we're better at identifying the exceptional responders and why that happened now at the genome level. So there are reasons certain snowflakes do better, and I think we're better at figuring out which one those are now. And I think that with correlates, we ensure that we're even better at that now, like so that it's not as random and we're more likely to pick up on it and stuff.
Okay, great. So, so many more questions to ask you, but I know you have to go and we are at the top of the hour. So just thank you so much, Dr. Reed, for joining us on OsteoBites today and making it better for pediatric sarcoma patients. More information on this and all OsteoBites can be found on our website at mibagents.org, on our MIB Agents YouTube channel, and at your favorite podcast place. And next Thursday on January 16th, please look out for a new episode of our Osteo podcast where co-hosts Mia and Sammy spill the tea on all things osteosarcoma and AYA cancer. This month, Mia and Sammy discuss cancer fatigue, how to escape the cancerverse. Spoiler alert, you can't really, but subscribe to Osteo on YouTube or at your favorite podcast place and never miss an episode. And then we hope to see you back here on OsteoBites in a couple weeks. We are going to be joined by Dr. Alexander Davies from OHSU. Dr. Davies will discuss how live cell whole tissue models reveal sources of dynamic signaling, heterogeneity, and single cell drug response variation in the metastatic niche. You can find our OsteoBites lineup for the next few months on our website. And if you have any ideas for topics that you'd like to hear about, please share them with us at events@mibagents.org. Thank you again, Dr. Reed, for spending an hour with us today. And thanks to all of you for taking time out of your day to hang out with us for an hour. We hope to see you back here in a couple weeks on January 23rd when we chat with Dr. Davies. Thanks so much, Dr. Reed. Thanks, everyone.